A surgeon reconstructs a torn ACL. Months of rest pass. The graft fully heals. But the moment the athlete plants their foot for a routine pivot on the field, the knee gives out again. Clinical oversight, rather than surgical error, causes these secondary tears. Standard rehabilitation protocols are critically incomplete. Athletes often equate the absence of pain and the ability to lift a moderate amount of weight with a fully recovered joint. Most physical therapy relies on restoring basic range of motion and building muscle through simple, isolated leg extensions. These linear, controlled movements do not prepare the knee for the unpredictable, exponential shear forces it will absorb during a high-speed athletic cut. Relying on a subjective reduction in pain to gauge recovery creates a dangerous blind spot, masking severe mechanical vulnerabilities hiding inside the joint structure. These traditional methods ignore the nervous system, which dictates how the leg aligns and stabilizes under sudden stress. Clearing an athlete to play based solely on how much weight they can push is a physiological gamble that leaves the underlying mechanics broken. The true mechanism of stability begins with joint proprioception. This diagram visualizes proprioception, the body's neuromuscular mapping system. Nerve endings inside the joint constantly communicate the leg's position and angle to the brain. When an ACL tears, those nerve endings tear with it. Surgery repairs the tissue, but leaves these neural pathways completely severed. Without those signals, the brain experiences a spatial blackout. When attempting a high-speed maneuver, the nervous system cannot quickly detect the knee's exact position. To cope with this sensory void, the nervous system unconsciously reroutes movement, relying on incorrect muscles and improper joint alignments to brace the unstable leg. These compensatory movements apply extreme, unnatural leverage against the knee, placing massive shearing force directly on the lax, healing graft. Until targeted neuromuscular re-education bridges that communication gap, the athlete is operating a high-performance machine with a disconnected steering column. The Karlos physical therapy approach treats the recovery process as an analytical performance lab, rejecting the generic routines of traditional clinics. This interface visualizes our initial data collection process, gathering objective movement kinematics, assessing joint load distribution, and identifying precise strength asymmetries. Before a single heavy weight is introduced, we must map and establish strict baseline neuromuscular control. Each recovery stage exists strictly to solve the physiological limitations exposed in the prior phase. This creates a rigid, 4-phase recovery protocol designed as a sequential biomechanical rebuild. Elite rehabilitation requires a carefully engineered progression of load tolerance, removing the guesswork by relying on measurable physiological adaptation. Phase 1 focuses on protection and control, prioritizing the reestablishment of the severed proprioceptive baseline. The immediate physiological goal is to use targeted, low-level muscle activation to mechanically pump excess inflammation out of the joint structure. Once swelling subsides and basic control returns, the protocol advances to Phase 2, the strength foundation. This graphic demonstrates the mechanics of eccentric training. Eccentric exercise builds strength by forcing the muscle to lengthen while under heavy resistance. During this controlled descent, the force is absorbed by the muscle fibers instead of the delicate connective tissue. This technique develops deep joint stability and load tolerance, safely strengthening the surrounding structures without pulling violently on the newly reconstructed graft. Mastering this eccentric control provides the exact physiological mechanism the leg needs to survive sudden, violent decelerations on the field. The protocol then expands into Phase 3, movement re-education, shifting focus from the isolated knee to the entire kinetic chain. A knee does not operate independently. Mechanically, it acts as a hinge, dictated entirely by the stability of the joints above and below it. Here are the gluteus medius and minimus muscles. Weak hip state pelvic structure level upon landing. The pelvis drops, forcing the femur downward, applying rotational strain to the iliotibial band and forcing the knee to collapse inward. This diagram shows proper leg alignment. The red dashed line traces directly from hip to foot. If poor arch control or flat feet cause the base to collapse inward, it drives an inward twisting force directly up into the ACL. Correcting these kinetic flaws sets the stage for Phase 4, performance integration. The training shifts from controlled, isolated joint movements to highly complex, multi-directional neuromotor tasks. We integrate reactive agility drills and unpredictable, sport-specific power exercises that force the nervous system to react instantly to external stimuli. Stabilizing the entire kinetic chain, from the arch of the foot up to the hip, provides the structural foundation required to transition from a surviving patient back into a high-performance athlete. Traditional orthopedic clinics often clear athletes using a time-based model, typically around 6 to 9 months post-surgery. Passing a certain number of calendar days and feeling subjectively ready are mathematically useless metrics for predicting the risk of re-injury. The Karlos methodology rejects arbitrary timelines in favor of strict data-based exit criteria. We require absolute strength symmetry benchmarks, meaning the repaired leg must output identical force metrics to the healthy leg. We must also validate the athlete's movement quality under extreme kinematic review, ensuring no compensatory mechanics appear during high-velocity drills. An athlete earns their clearance only when these objective load tolerance metrics hold up under states of severe physical fatigue. The result is a fast, flawless directional change, executed with absolute structural confidence. Effective rehabilitation targets a ceiling higher than the pre-injury state. The objective is a structural and kinetic efficiency that surpasses the athlete's original condition. Karlos Physical Therapy provides the precise biomechanical framework to safeguard your physical career, rebuild your movement mechanics, restore your baseline performance, and systematically mitigate the mechanical risks that lead to structural failure.